People were all like, Sir Eldric, why aren't you making any videos? So I'm all like, I know what the people want. Surveys. My most watched videos of all time are my Survlogmores. They love Survlogmores! Yes, they do. Anyway, there's two surveys. I got them both in the mail today, so we're going to take them. The first one is oral chemotherapy, a pharmacist's perspective. As the treatment of cancer evolves, so do medication options. In 2012, the FDA approved 8 new oral chemotherapy agents. This is very important because historically, all the chemotherapy agents have basically been IV only. So you have to deal with coming in and getting injections and all kinds of and infusions. But now they have oral ones. And so now it's going from a hospital issue to an outpatient issue. As these agents become more readily available, the pharmacist's role in education and safety will expand. Yeah, because now you've got like your guy down at Walgreens or CVS having to counsel you on your chemo agent. Purpose of the survey is to evaluate the pharmacist's knowledge, evaluate current practices in regard to oral chemotherapy, and evaluate the preferred method of education. Excuse me. The purpose of the survey is for research and has been approved by IRB. That stands for Institutional Review Board. That means that a group of experts have said, yeah, you're probably not violating any ethical issues by asking these questions. Usually it's done for like actual research. You have your ethics review board making sure that you're not going to harm patients when you do your research. All data collected will be confidential and no personal identifiers will be collected. Participation in the study is completely voluntary and no negative consequences will occur if you choose not to take the survey. You're free to not answer questions or withdraw at any time. Clicking on the next button means you consent to the above terms. How many people actually read the above terms prior to clicking next? Licensed and practicing pharmacist in the United States. That's me! I'm licensed and I'm practicing. They call it practicing because I'm not yet good enough. No, that's not true. Alright, so next. Now, the email that came with this specifically mentioned that it is meant for everybody. You don't have to have any prior experience with chemotherapy at all. We want a wide range of opinions. So I'm male. I'm in there. I'm a PharmD. I also have residency. I'm not done, but I'm going to click it. What are your credentials? I don't have any Wait, why does fellowship count as a credential? That's not fair, man. That's not cool at all. So I've explained in a previous video the difference between a residency, which is pharmacy practice-based, where you're actually learning to do pharmacy practice, like what a pharmacist does. And then there's fellowship, which is research-based. Of course, it ties into pharmacy practice, but the emphasis is on the research portion and not the actual pharmacal... I'm trying to think of the word for it. Patient care. That's what I want to say, patient care. This stands for Board Certified Pharmacotherapy Specialist. This is Board Certified Oncology Pharmacist. So I'm neither of those, nor do I have a fellowship, and that's also fellowship compared to board certification. My gosh. Which best describes your practice setting? Ambulatory care. Of these, best describes my practice setting. I am employed by a university, but I don't practice at the university. I practice in ambulatory care for the most part. Describe your area of specialty. Ambulatory care. Yeah, I guess if you choose like hospital or specialty pharmacy down here, you would choose a... But yeah, ambulatory care is my area of specialty as of right now. Next year, it will be infectious disease. How many years have you been a practicing pharmacist? Less than 5. Does your site dispense oral chemotherapy agents? Please exclude immunosuppressant agents such as methotrexate, hydroxyurea, and azathioprine. I just had a patient on azathioprine the other day for pulmonary fibrosis. Examples of oral chemotherapy medications include, but are not limited to, Tarceva, erlotinib, Xeloda, capecitabine, Nexavar, sorafenib, Inlyta, exitinib, and Zelboraf, vemurafenib. Okay. I don't know if I've ever heard of Zelboraf, vemurafenib. Okay, of all of the places that I have been, I did have a patient who was on azathioprine, but nobody who was on these medications. I have myself dispensed when I worked as a pharmacy technician. Technically, I myself did not dispense as accordance with the law. I assisted the pharmacist in dispensing Tarceva and Xeloda. But where I am right now, no. Next. Thank you for I was hoping it would just say, like, your survey is completed. You are done. Does a pharmacist at your site provide patient counseling for oral chemotherapy agents? Where I am right now, I'm at a CBOC, which is, I was about to say it's VA speak, but I work right now with a Veterans Affairs hospital, and the CBOC stands for Community-Based Outpatient Clinic. And at the CBOC, so you have a VA hospital, and in the surrounding area, usually located between like half an hour to an hour, maybe even further from the main VA hospital, they place these CBOCs so that it's more convenient for the veterans. They don't have to constantly drive like an hour to get to the VA hospital. They can receive their care closer to home. And I'm at one of these CBOCs right now. And while we're there, we're doing disease state management, so diabetes, hypertension, hyperlipidemia. Different than most of the other places I've been so far, because of this clinic, it's actually pharmacotherapy. So it doesn't have to necessarily pertain just to those disease states. I can actually deal with any kind of medication that the patient's on. Now, of course, if a patient came to me and they were on a chemotherapy agent, I'm not going to be the primary person for that. But if I do notice some issue, I totally get to address it. I don't have to not necessarily ignore it, but it's something that's still on my radar and I'm still responsible for it. Whereas when I was working at, for example, the cardiology clinic, I was pretty much supposed to just deal with the cardiovascular issues. If I noticed an issue, I could address it, but I didn't have to. Whereas in the pharmacotherapy clinic, you need to be on top of all of the issues, not just the normal disease states that they're typically referred to you for. So does a pharmacist at your site provide patient counseling for oral chemotherapy agents? I'm going to say no. There's only one pharmacist at this CBOC, and she does a lot of stuff, but I believe that she has not yet done any oral chemotherapy, because we were talking about the azathioprine for my patient, and she had mentioned that she doesn't usually deal with that kind of information. So we're going to deal with the next. What do you feel are barriers to counseling on oral chemotherapy agents? Not lack of time. I do believe that it would be a barrier for most people. Your average pharmacist particularly a retail setting, they're not going to feel qualified. So that's a lack of knowledge. And they're also going to say that the patient's probably already been talked to by their oncologist. Oncologist or nurse should provide counseling. I don't think it's necessarily that they should provide the counseling, as in it should be their duty and not my duty. I do believe it should be their duty as well as my duty, so I'm not going to click that. Lack of other people might think lack of time. Describe your confidence level of counseling. Okay, no, not really confident. I'm more than not at all confident, but I'm pretty much in the not really confident region. Oncology was the very last thing we learned in pharmacy school, and I have not had any practice experience in oncology, other than the agents that they're not dealing with specifically. Like, I've dealt with methotrexate, I've dealt with hydroxyurea, I've dealt with azathioprine. Those are the more common and historical outpatient, but they're not directly the chemotherapy that you usually see. This is, I guess, more aimed towards the newer, really chemotherapeutic agent kind of deals. What do you feel are the most important counseling points for oral chemotherapy? Please pick the 3. Side effects. Oh man, I can only pick 3. I do think administration is very important. Safety is very important, but I'm going to tie safety and side effects together in my mind. Storage and handling, for the most part, when they're getting them into these tablets, the storage isn't necessarily as important. For the most part, you can treat almost every tablet kind of the same. You deal with, keeping it away from moisture, away from heat, away from light, keeping it sealed in its container. But there is definitely some handling issues. There are certain medications, and this isn't even getting into the chemotherapy. There are other medications that are specifically said, if you're a woman, don't touch this medication. There's some of the prostate medications for men. They say specifically pregnant women should not handle this medication at all. And so I know that there's issues with handling. I mean, if you're dealing with these chemotherapeutic agents, you certainly don't want other people being exposed to them. Drug interactions are very important as well. But as far as counseling it to the patient, I wonder offhand how much of these chemotherapy agents significantly interact with over-the-counter medications. Because if it's a prescription medication, it should definitely be, should have been reviewed by the oncologist prior to prescribing that particular therapy. And second, for any new agents that are prescribed by, the primary care physician or what have you, they should definitely already be aware of the fact that there are these chemotherapy agents on board. There's definitely some communications issue if you're the primary care physician and your patient hasn't told you that they have cancer and are receiving chemotherapy. Administration is very important. You don't want to take too many. You don't want to take too few. You want to make sure you're taking them at the right time of day. If it needs to be taken with food, you definitely want to make sure. I mean, these things are meant to treat like cancer and other related diseases. So, like some autoimmune diseases and what have you. I'm going to say handling. I mean, this isn't something that necessarily needs to be repeated every single time that they pick it up. So my mind is immediately going to first time use. And I think how to take it, what we can expect, and how to handle it are very important. So I'm going to choose those. Describe your level of familiarity with risk evaluation and mitigation strategies to prescribe and receive. Okay. Your level, with risk evaluation mitigation strategies to prescribe and receive, My level of familiarity with REMS, as they're called, is high. But my level of familiarity with REMS, specifically to prescribe and receive an oral chemotherapy, I am not at all familiar with those REMS. Risk evaluation mitigation strategies, it used to be that if the FDA thought that a drug could be used and approved it to be used, but they thought it might benefit from extra safety concerns, they would use a medication guide. And so it became essentially law that if you were to that sounded weird. If you were to dispense a medication, you had to give the medication guide with it. It was automatic. You had to give this medication guide to the patient. Well, you hand a piece of paper to the patient, they may or may not read it. They may or may not understand it if they do read it. And they may or may not follow along with the suggestions if they read it and they understood it. So the FDA has changed the REMS to be more than just medication guides. They're just the most common. There are restricted prescribing where you have to have a certain certification just to prescribe it. There's a set of medications called isotretinoin. They're used to treat acne. But they're very, very teratogenic, which means that they cause deformities and even deaths in unborn children. And for that, in order to prescribe it, you have to be the doctor has to be registered with the iPledge program, and it requires you to do certain blood work, and the patient has to complete an online it's a test basically. To show that they understand all of the risks involved and all of the ways that they're supposed to take the medication. And then there's a time limit. So once all of that has been completed by the doctor and by the patient and put into the system, it spits out an authorization number. And that has an expiration date. And for women, unless it's changed, I think women have 7 days to fill the prescription, and men have 30 days. And if you take too long to pick up the prescription, then that authorization is null and void, which means the prescription is null and void, and you have to go back through the process. There's another medication, it's Suboxone, which is used a lot of times for treating substance abuse addiction. And you have to be specially registered as a prescriber to prescribe that medication. Those are kind of tied into the REMS philosophy. Which resources do you utilize before counseling patients on oral chemotherapy agents? Okay, I'm going to use the package insert. I'm going to use a drug database. I may or may not use this. The drug manufacturer's website. Probably not, for the most part. The only time I'm going to use Wikipedia or Google is if a patient asks me a question that I can't find in the package insert or drug database. I might then go to Wikipedia or Google. I also think Micromedex ends in an EX, so this is misspelled. I could be wrong, but I'm pretty sure that Micromedex is MedX and not MedX. But maybe I'm wrong. Could be Micromedex. Lexicomp. Yeah, so those are probably my two biggest ones. How important do you believe it is for pharmacists to be educated about oral chemotherapy agents? For pharmacists, I think it's somewhat important. Your average pharmacist is probably not going to have any dealing with this, despite the over-the-counterness of it. Not the over-the-counter, wow. Despite the oral, the existence of the oral agents right now, and even given the prevalence of cancer, you know, of all of the people that have cancer, only a very small subset have an oral agent that would be appropriate, and only of those where an oral agent exists, only a small subset of that are going to actually be prescribed the oral agent. And so you have a very small population going around. Now, for once you do have an oral agent and you have to dispense it as a pharmacist and counsel on it, very, very important that you're well educated on the topic. But as an overall average, it's not that many pharmacists that have to deal with it at present. Now, over time, that's going to become more and more important, which is why I say it's somewhat important, because, you know, the number of aging patients who are going to develop these types of cancer, the development of future and further oral chemotherapy agents and their availability, those are all going to increase with time. Have you received any education on oral chemotherapy agents? Not outside of the ones that... Technically, yes, I did receive education, and in fact, it happened during my pharmacy school education. But I don't think that's what this question is asking me. I think it's asking me about further education beyond what would be in a regular pharmacy school curriculum. But, you know, I could put this yes or no. There's no option to put comments, so I'm going to say no. If there was an option for comments, I would add the comment in that, yes, I received it, but it was just my pharmacy school education. All right. Had to pause there for just a sec because I really needed to blow my nose. How would you prefer to receive education on oral chemotherapy agents? Please choose your top two. Yes, speaking with a drug representative. No. Formal continuing education, package insert, manufacturer. How would you prefer to receive education? Package insert? Really? No. On chemotherapy agents. I guess I would like to receive education via primary literature and a drug database, I suppose, if I had to learn about chemotherapy agents. Package insert is good to look up information, but that's not necessarily how I want to learn about the drug. That's a harder question than I would think it is. How would you prefer to receive education? Yeah, when it says education... Drug database isn't the way I want to receive education. I suppose continuing education and primary literature is how I'd like to be educated on it. Do you feel that your pharmacy education provided you with the necessary tools to counsel on oral chemotherapy agents? Do you feel that your pharmacy education provided you to counsel? I do believe it provided me with the necessary tools. Somewhat. I don't necessarily think that just from the lectures that we had in class and what have you that I would be 100% confident and ready to go. Oh, hello, we're done. Okay, so that's survey number 1. Feeling charitable? All right, so now we have the University of Illinois at Chicago College of Pharmacy, which this is a survey on academic cheating sent out on the ethics listserv. And the survey is going to be used to identify 10 to 15 individuals who will serve as experts in a Delphi process. And the Delphi process, what that is, everybody answers the questions, and then the results are kind of summarized, and then they answer the same questions again, or very similar questions, and it goes over for a number of rounds in that way. And the idea is to build towards a consensus. And so by utilizing some experts and then having them go through this process, they kind of narrow down the wider opinions, getting closer and closer to a particular answer, I suppose. And it dealt with, if I remember the email correctly, I don't know if they were trying to come up with a definition of academic cheating and other kinds of things like that. I'm not sure. All right, this should work. Are you a pharmacist? Yes, I am. How many years have you been in practice? 1. Have you precepted pharmacy students within the past 5 years? Yes, but not as their main preceptor. So I'm going to say no, because I wasn't their actual preceptor. Are you currently, or have you ever been? No. No, I have not. Oh, APPEs is Advanced Pharmacy Practice Experience. Those are your 4th year rotations as a pharmacy student. Please complete the following table describing your participation regarding committee service, focusing on academic integrity and or academic dishonesty within pharmacy education. The main reason I'm taking this survey is as part of my academic administration rotation in residency, we completed a focus group with the faculty on what's called the APS code, or the Academic and Professionalism Standards Code, I believe is what that stands for. But essentially, if you're caught like cheating, then you get an APS violation, and an APS report is written, and then you meet with the dean, and all kinds of bad stuff happens. But the same APS process is used for insubordination in class, or inappropriate dress, something that's out of the dress code. Pretty much anything that violates academic standards or professionalism standards can be filed under an APS violation. So, am I the chair of a committee or work group or task force? I was a member of a task force, and that was in 2013. And task force is like a strong word for running a focus group. So what's my next question? Come on. Why is my internet so slow? Please complete the following. Okay. Have I published manuscripts? No. Presented a poster? No. Facilitated workshop at a professional meeting? No. Provided consultation? Kind of. I didn't receive an award for it. Okay, I did one, and it was in 2013. I mean, I suppose if you ran a focus group, and based on the I had to write up, myself and the other resident, we wrote up the questions for the focus group. We met with the focus group, which was about 10 faculty members chosen at random from the faculty. We asked them the questions. We recorded their answers. We summarized their answers and wrote a report, which was then submitted to the dean. And actually, just yesterday, we had a faculty meeting, and it had been about a month since we ran the focus group with the faculty. And based on one of the suggestions in our report, the dean at yesterday's faculty meeting presented a summary of APS violations for the current academic year, because one of the points of feedback we got from the faculty was that they didn't feel like they knew what was happening. So they would write an APS violation for a student, and then they felt like that was it. They never got any follow-up. They never got any closure to it. It was something that happened out in the executive sphere, because the faculty themselves are not directly involved in the resolution of an APS, or they're not necessarily involved. The APS code doesn't require them to be. It's referred to members of the executive committee, which is made up of like the deans of the school, and the executive committee then handles it. And that kind of, they're supposed to be like an objective third party, because they're the executives of the school and not the faculty, not teaching the classes with the students, and so they kind of stand apart. It's meant to be to remove the kind of, maybe prejudice that you'd get if you were being judged by another faculty member, since the two faculty are, same ranked kind of colleagues, whereas the executives are kind of up a bit. Just like if you're in the workplace and you have an issue your boss, will take it up, and then someone like from HR will handle it, or like their boss will handle it, rather than having some of your coworkers come together in a council to determine what's going wrong. Things like that. I have not taught an entire course. Wait. Regarding teaching about academic okay, yeah, so I haven't taught a course on it. I haven't taught a lecture on it. And it's not a workshop, so I don't think I facilitated a workshop on it. What? No, you don't get to know my name and title. This interview is over! So I will fill this in, and that'll probably be the end of this video. So until next time, by the way, I have like a 0% chance of being chosen as one of the experts on this panel, but I'm going to use it anyway. Didn't I enable JavaScript? I thought I did. Where's my... Oh well, we'll deal with it later. Bye-bye.